Hello, this is part 10 of our systematic approach to ECGs. And in this part, we're going to look at the QRS complex. So let's get started. We're doing our systematic approach to ECG analysis. And now we've gone through the rate, rhythm, possibly evaluated the axis. And now we're going to focus on the QRS complex. And the two things I want to focus on are whether the QRS complex is wide or narrow, which we've already evaluated a little bit in the rhythm, but we'll look at more in a more focused fashion now. And then we'll look for Q waves. So asking ourselves, is the QRS wide or narrow? Looking at this ECG. So let's blow this up and look at a specific section of the ECG. And you want to take an area where you can see the QRS very clearly. And then if you count the small boxes there, you'll see that this is about 4 small boxes is the width of our QRS. Each small box represents about 40 milliseconds. So this is about 160 milliseconds. And up in the upper left-hand corner of our ECG, you can see that the computer read the QRS duration as 158 milliseconds. So they're consistent. So this would be a wide QRS. Anything greater than 100 milliseconds, as we said before, is considered wide in an adult. Anything greater than about 80 milliseconds, wide in a child. So you found that there's a wide QRS, but now why is the QRS wide? It's not just enough to detect it, but you have to have some differential diagnosis that goes through your mind when you see or identify a wide QRS. And there are 6 key reasons you can have a wide QRS that you should know about and think about when you see that on ECG. And here they are. Ventricular rhythm, which we've already talked about, and bundle branch block, which we talk about separately, a paced rhythm, electrolyte abnormalities, especially a high potassium, certain drugs, and classically we think about a tricyclic antidepressants causing a wide QRS, and then Wolff-Parkinson-White syndrome, or WPW syndrome. As we said, ventricular rhythms and bundle branches we'll talk about separately. So let's take a look at this ECG. On this ECG, you can tell immediately just that this is not a normal ECG. But if we blow it up, what are we actually seeing? So looking at V1 a little more closely, you see these abnormal appearances which right before the QRS complex and right around the area of the P wave. And this is actually an atrial pacer spike. So this is someone with a pacemaker. And they have a pacemaker lead in the atria that's controlling the atria. And that's where you see this small spike. This large spike is a ventricular pacer spike. So people can have either a pacemaker that controls the entire heart from one atrial pacer spike, okay, and then it goes down the normal electrical pathway, or they can have a pacemaker that controls it by just putting a lead into the ventricle, where you may see a P wave, and then you'll see this large ventricular spike right before the QRS complex. Or you may have, like this patient does, a dual pacemaker where there is a lead in the atria that fires and a lead in the ventricle that fires as well. So these are pacemakers, and you will see a wide QRS complex if the patient is ventricularly paced, because as we've said before, it's not using the normal electrical pathway or our superhighways. Let's take a look at this ECG, and we'll do our typical evaluation of the ECG using our systematic approach. But I'm going to skip us forward, and let's focus in on this section of the ECG. What do we see here? Well, we see that the QRS complex is wide, right? It's about 3 small boxes, or 120 milliseconds. And we can confirm that by looking at the computer read. The other thing that's pretty abnormal when you look at this in V3 is this tall peaked T wave. So if you see a wide QRS or you see tall peaked T waves that would look painful to sit on, those are both signs of hyperkalemia, which can be a life-threatening condition where patients can go into a ventricular dysrhythmia very easily. So you don't want to miss this on ECG. What about our other causes of a wide QRS? We mentioned drugs such as sodium channel blockers, especially tricyclic antidepressants. And the last one was Wolff-Parkinson-White, or WPW syndrome. In WPW syndrome, if there's no other conduction abnormality, you normally see a QRS duration of about 100 to 120 milliseconds. And you see this slurred upslope. And that slurred upslope happens because of this accessory pathway between the atria and the ventricle. And that slurred upslope is frequently termed a delta wave. Okay? And a delta wave is a sign of Wolff-Parkinson-White syndrome. You can't always see a delta wave in WPW, and typically it can be hard, even when it is present, to identify if it's truly a delta wave or not. But this can be a condition that patients can be at a high risk for dysrhythmias, so we do want to identify it, and it does change our management if the patient does come in with a supraventricular arrhythmia. So it's something you do want to know about and think about when you see a wide QRS. So don't forget the 6 causes of a wide QRS. It's critically important when evaluating an ECG. So ventricular rhythms, bundle branch blocks, paced rhythms, electrolyte abnormalities, especially hyperkalemia, drugs, and WPW syndrome. Our second part of the systematic ECG analysis of our QRS complex is to look for Q waves. So when we look for Q waves, we're looking at our QRS complex, and it's called a QRS because if the initial deflection is down, that's a Q. The first deflection up is the R, and if there's a deflection after the R that goes below the baseline, that's considered the S wave. So there's multiple ways you can have a Q, but really what it means is that the first deflection is down. So in this QRS complex, all you have is a downward deflection. So this is just a Q wave. It's still called your QRS complex, but it's entirely consistent of only the Q wave. So let's look at this ECG and see, are there any Q waves present on this ECG? Is there any part where the QRS complex initially deflects downward? If you look carefully, you can see there are a number of leads which show an initial downward deflection. Even a slight upward deflection, you would not call it a Q wave. But in lead 3, V1, and V2, you don't see any initial upward deflection of the QRS complex, so those are Q waves. Now, large Q waves, okay, can be a sign of an infarction. They can be the sign of an acute infarction, but most often when you see them on ECG, they're the sign of an old infarction. Small Q waves, however, can be normal in certain situations. So small Q waves, about 1 small box in width and height, or less than 1 small box, okay, can be normal in leads V5, V6, in the inferior leads. And you'll see those not infrequently. Most Q waves, even the small ones, are pretty abnormal though if seen in V1, V2, or V3 in their septal leads. You can occasionally have a normal finding with septal Q waves, but it's pretty rare. So most of the time if I see Q waves in the septal leads, I'll be concerned that that's a sign of either a prior or ongoing acute myocardial infarction. So in summary, our QRS analysis. We want to remember our 6 causes of the wide QRS as listed here. And we want to remember that abnormal Q waves, okay, especially large Q waves, can be a sign of a prior infarction or even an acute myocardial infarction in the right setting or other findings on ECG. Thank you.